Good evening, dear Foxians and our esteemed viewers. I, Dr. Suman Sinha, Chairperson Vaginal Surgeries Committee FOGSI, your host for today's podcast, welcomes you all to the Enriching Gyan Pravah Flow of Knowledge podcast episode number 148. I will always be there on 25th of every month at 8 p.m. to share with you different topics, maybe educational, administrative, political or spiritual content. ज्ञान का बहता रोजाना एक नया रंग हर रात 8 बजे जुड़िए आप फॉक्सी के संग. I now will be taking you through a very inspirational journey and success story of a trailblazer in the field of urogynecological surgeries, Associate Professor Obs Gynae and Reproductive Sciences, Dr. Apurva Pipin Pancholi, who is posted in MC Governed Medical School at the University of Texas, Houston, USA. He is a person with high degree of aptitude, skill, and creativity, achievements, and accomplishment. He is very passionate about teaching surgical skills to generation next. And thus he has dedicated himself to academics. On behalf of FOGSI, myself, and Dr. Palani Appan, I extend to you our warmest welcome. Thank you so much for accepting our invitation. This Enriching Gyan Pravah series is a prestigious initiation solely conceptualized and executed by our beloved President FOGSI, Dr. Sunita Tandulwadkar. It aims at fostering knowledge, discussions, and growth. Madam is a synonym of excellence, innovation, and leadership. Before I begin the podcast, I take the privilege to honor, invite, and welcome a great visionary, resilient, and dynamic Vice President FOGSI, Dr. Palani Appan sir. He is a great scholar, great academician, surgeon of par excellence, and when he presents, whole hall keeps quiet because his presentations are superb, and I don't know how he makes it so attractive, so many videos, so many our ancient Mahabharata and Ramayana, everything included in it, whatever topic he chooses. So welcome, dear sir. And I would like you to address the gathering and also welcome our guest faculty today.
Good evening, ladies and gentlemen, and my dear family members of FOGSI. It's been fantastic journey for the last almost 6 months, 5.5 to 6 months now, under the visionary leadership of Dr. Sunita Tandulwadkar. And when we all started working for FOGSI and for Dr. Sunita maybe a year back. So I always used to tell that our tenure is not 1 year, it's 1.5 years, or maybe 1 year and 9 months. So when we started doing that, this concept of Gyan Pravah podcast was conceptualized by her, which is a very, very different initiative of Dr. Sunita, because all the chairpersons are absolutely involved in the work and they are not left out. So when they ever given a day to do the podcast, 8 o'clock every day, whatever you may be doing, whether you're in the clinic, whether you're in the hospital, whether you're in your bedroom or whether you're in a kitchen, you can probably switch on the podcast and listen to the chairpersons speaking on or interviewing a visionary leader of some particular branch. May it not be an obstetrician gynecologist, it could be an entrepreneur, it could be a politician, it could be a sports person, it could be anybody for that matter, somebody who will give some words of wisdom. So that was the idea of Dr. Sunita, and this is probably the 147th, 148th recording we're having, and then it's going on, and at 8 o'clock. It's been an absolutely fantastic event, and the feedbacks which come from everybody has been absolutely wonderful. And with Dr. Suman Sinha, the person who's behind the vaginal surgery committee, has been doing absolutely wonderful work, Dr. Suman, and keep it up. And we are very, very happy to have Dr. Apurva Pancholi from the US. And we could know from his designations what work he's done so far and how apt he will be to your podcast today. And it is absolutely very, very good that we have this particular person, Dr. Apurva Pancholi from the US, and with you, Dr. Suman. And over to you, without wasting much of my your time and FOGSI people's time, I hand over the mic back to you, and all the best for a lovely, wonderful podcast this evening. All the best to you and to Dr. Apurva Pancholi.
Thank you so much, Dr. Palniappan, for being with us today and addressing. Just a minute. So, before that, I would like to tell the gathering little bit of initiatives of our President FOGSI. So, Dr. Sunita Tandulwadkar, through her amazing projects like Sampurna, Know Your Number, Anubandh, Arogya Yog Yatra, Aprajita, she has touched the lives of many women across the country and beyond. Her initiative, Swasth Nari Abhiyan Yatra, is gaining momentum, which carries her mission to spread awareness about breast and cervical cancer prevention from Kashmir to Kanyakumari. So now I'm really blessed to have Dr. Apurva Bipin Pancholi with us, and I would like to share his accomplishment and about him to the gathering. It's really a proud moment to have Dr. Apurva with us. So, Dr. Apurva Bipin Pancholi is MD and he is Associate Professor of Obstetric Gynecology and Reproductive Sciences in the MC Governed Medical School at the University of Texas Health Sciences, Houston, USA. He has done Bachelor of Science in Microbiology in 1987 to 1992 from University of South Florida, Tampa. He completed his Doctor of Medicine 1992 to 1996 from University of Miami, Florida. He did his post-residency in obstetric and gynae in 1996 to 2000 from Newark Medical College. He received fellowship in advanced pelvic surgery 2002 to 2003, fellowship in female pelvic medicine and reconstructive surgery in 2007 to 2010 from Good Samaritan Hospital, Ohio. There are numerous awards and honors to his kitty. His name featured as top doctors in Houston magazine, received Surgeon of Month from the Herman City Hospital. He is also recipient of Dean's Teaching Excellence Award from MC Governed Medical School at UT Health. He is presently in the American Board of Obstetric and Gynecology and also oral board examiner since 2023. He has, to his credit, several publications and presentation at national and international conferences. And there are many more to come. And now I request our Dr. Palaniappan, if he's there, again to give us a nod to start the podcast with Dr. Apurva. I think he has left, so we'll go with the questions. Dr. Apurva, I can see you from your CV that you are an American citizen. But your name suggests your Indian root. Where it is, and kindly tell us about yourself.
Sure. Well, first of all, thank you so much for having me and inviting me for this podcast. I want to thank the Honorable President, Dr. Tandulwadkar, Dr. Palniappan, and also the FOGSI, the whole membership, for inviting me. It's an honor to be part of this. And when I got the invitation and I saw the Gyan Pravah, series, and I really enjoy teaching, and I really feel like the Swasth Nari, movement is critical. There needs to be more and more that needs to be done in this field. And so this was an opportunity for me to be on a stage and discuss about a Urogyn topic, something that I'm very passionate about. So I want to thank everyone, and thank you, Dr. Suman also. I've shared, the dais with you before and virtually and other meetings, and it's always an honor to be with you and, in any presentation. So thank you again. I do want to, just share my story. I'm originally from Ahmedabad. I'm born in Ahmedabad and did my primary school, everything in Ahmedabad, and then moved to New Delhi. So I grew up in Delhi, and I always jokingly, say, people always ask me, where are you from? I always say Delhi, because my teenage years were in Delhi, and so that's most of my memory and everything is from Delhi. So, but my wife is Gujarati also. She's from Ahmedabad, so if she's with me, she always says, how come you never say Ahmedabad? Are you embarrassed or something? So that is not the case. I'm very proud, to be Gujarati also, but, Delhi was home. Delhi is still home for me. And so that's where I grew up. I came to United States with my parents, actually. I got lucky. I also tell everybody, that, medicine in India is so competitive. It's, it's a next level kind of competition, something that, other people don't realize and everything. So I don't know if I would have, taken that path if I was still there. But right before 12th standard, I came already, to United States with my parents. And so I did my undergrad college, and undergraduate in Florida. Tampa, Florida is my second home. And so I did my undergraduate there. I ended up going to University of Miami for my medical school. And then OBGYN was also, something surgical. That was my, my dream. I wanted to do something, with my hands, something I can actually, make better immediately. And so I wanted to do something surgical. I initially actually thought I would be a trauma surgeon, but trauma surgery requires a whole different type of personality and everything. And so I identified myself more with the OB-GYNs. And so we gynecologists, we are milder surgeons, if I put it that way.
Yeah.
And so I decided that, this is the field. And my mentor actually, it was a GYN oncologist at that time. And I just was mesmerized the way.
Who was your mentor at that time?
I'm sorry?
Who was your mentor?
So Dr. Manny Penalver. Dr. Manuel Penalver, he is a GYN oncologist, and he is just a phenomenal surgeon. To be in the operating room with him as a student, it was almost like an orchestra, performance. His every move, every incision, every stitch was just amazing. And so I wanted to be like him. So my initial passion was actually GYN oncology. I thought that I would be, be a GYN oncologist and, take on the most toughest surgeries, because oncologists do some amazing surgeries. So that was my passion initially. But I ended up doing my residency in New York, and my residency program was a very small program. And so, one of the things is that, it's a very, oncology is a very competitive field. So there's not too many spots, at least back then. There weren't too many spots available for fellowships. So I remember my program director telling me that, it'll be very difficult if you want to do oncology. So think about something else. And so I actually, decided to pursue just, general practice. I did general OBGYN. I worked in a private practice for a while. Then I worked under another GYN oncologist for a while. And then I went and worked as a laborist, just to deliver, just to obstetrics. And I did that for almost 8 years. And then after that, while I was doing that, I used to apply over and over. It took a few tries. Even then it was very difficult because you're a gynecologist.
Coming to the questions, so coming to that question also. So thank you very much. It was wonderful to know about you, because really wondering how come an American citizen have this type of name, I was thinking. So now it's quite clear to our viewers also that you have a root in India, and especially Ahmedabad. Today, Ahmedabad has become, it is in tips of all persons. Everybody discussing about this devastating accident which has taken.
Yes.
So you have done your undergraduate, graduate and postgraduate studies all from USA. Please highlight the education system in USA for becoming a medical professional. There are many doctors whose children, they want to go to USA to study medicine. I mean, they want to do their +2 in India and straight away they want to apply. So is it possible for them to go to any foreign nation and take up medicine? Is it
Yes.
possible? Like engineering
So
students, they go, they take up engineering classes, they become engineers over there, then they get a job. So that channel is easy. But what about students who are who want to become doctors?
Sure. No, that's a great question. So, medicine, I think any field, in US, the one thing is that, it requires some kind of undergraduate training. Even if you're part of a program, you do a couple of years, 2 years undergraduate, or if you do what I did, what they call 4+4. So you do 4 years of undergraduate, you do a bachelor's degree. It can be a bachelor's of arts, bachelor of science, or something, and then you apply to medical school. And so, and then, like I mentioned, there's some BSMD programs where you do either 2 or 3 years of undergraduate and then apply for medical school, which would be another 4 years. So anywhere between 6 to 8 years of training is required for the MD degree. So as long as somebody is willing to, take the undergraduate track first, and then, do the core requisites that are required. There are some classes that are mandatory, and then everybody has to take an admission exam, which is the MCAT. So MCAT exam is something that you take, and then based on your undergraduate merit and the grades and everything, and then the MCAT score, and then nowadays it has, you have to have, we want a holistic view of somebody who's going to be a doctor. We don't want somebody who's just book smart or anything like that. So what else have you done, as far as, something towards this noble field, So have you shown any volunteerism? Have you done any extracurricular activities? Is there a journey that you can show that you were working on towards medicine? So that is required.
This MCAT exam is MCAT exam, no? MCAT.
Yes.
So is
MCAT.
it is, they have to do in US only. It is not the people staying in India can apply for that. Is it like that?
So I don't know that. I'll be honest with you. I don't know if people in India take it, but it's there are certain testing centers in the United States that you have to go to. It's not even something that you just take it, from your medical school class or anything. You have to go to certain testing centers where it's administered, and then you can take it. I don't know if there's testing centers in India that are certified to allow that, but I'm pretty sure there must be.
Thank you. You have a extremely promising and brilliant academic background, and now you are associate professor, Urogyne, in a very prestigious institution. Was the journey smooth, or you had some hurdles?
So I always, talk about my journey to my residents, and I tell them, I had to move around, to get to where I am and everything. So, but each move has been something that has been, promising or, leading to something that I wanted to do. So, like I mentioned earlier, I used to do, general OBGYN and work in a very small town in northeast part of Ohio.
General OB-GYN is what?
Yes.
What is that?
In a small town in northeast Ohio.
Ohio, yeah.
Yeah, so it was a very small town, but it was a great experience, and it also allowed me to apply during that time for my fellowship. And then once I did my so for my fellowship, then I had to move again, because my fellowship, I was actually very fortunate. I got to train in Cincinnati, Ohio, and for urogynecology. And our program in Cincinnati, my program director, Dr. Mickey Karam, is the author of our urogynecology textbook. And so I was so fortunate to train under Mickey, for 3 years. So that was like a dream. And so then for that, I had to move. And then, when I took my job, I was with another university in Houston. And then my passion was to be out in the community so I can help more people. So I used to work in Texas Medical Center, which is the capital of the world for healthcare. It's the biggest, largest medical center in the world, and it was a great experience. Loved it, but it was very difficult for patients to come there. And most of my patients are elderly. It was hard for them to drive to a downtown kind of an area. So I wanted to be outside in the community, so it's easier for patients to get the access. So again, I moved and I changed my job, and so hence I'm with UT. And so UT offers me that opportunity to be out in the community in Houston.
And what is UT full form?
University of Texas.
The University of Texas.
Yes. So UT Houston. Yeah, that's my current employer.
Thank you. You have taken medical. You have done fellowship in urogynecology and pelvic reconstructive surgery, which in itself is a very complex topic. We would like to listen from you, your work responsibility in your hospital.
Sure. So right now I'm full-time faculty. So my main role is to be faculty for the residents. So I enjoy teaching. I've always been in, since my fellowship, I've always been in academics. So I really enjoy teaching, and so that's been my passion. And I do have a private practice also under the University of Texas's, flagship offices. But my main job is again in teaching. And then I also serve as a medical director for the Pelvic Floor Health Center at our hospital. And so basically we are offering all urogynecology services. So we are a referral center, a tertiary care center. So anything that's out in the surrounding community that if somebody doesn't feel comfortable taking care of, or if a patient hasn't had any successful outcome or anything like that, then that gets referred to the university. And then so at the university, we take care of patients, who have wide array of symptoms. So we usually just say any pelvic floor issues, anything from pain issues to bladder issues to, vaginal issues to prolapse, fibroids, bleeding issue, anything like that. So, anything that comes to, that other people don't want to take care of, then at the university, we are happy to take care of it.
So is the days fixed for surgery, or any day you can perform surgery? Your days are fixed.
Yeah, so we try to, we don't want to have patients just have, move around and everything. So we try to keep certain days just for our, clinic, which is the OPD. And then certain days are just surgery days. So that way, the good thing about urogynecology is that most of our surgery, I should say, are elective surgeries. So we can schedule them. We can say, okay, we'll do this surgery on such and such date. So that way, there are some complex patients, right? There are sometimes cases where we have to combine with colorectal surgeons, or if somebody has any really bad fistula that we're repairing that needs, urethral surgery also being done, then we combine it with urology and other specialties. So then we schedule those. So my typical weeks, will be having Monday, Wednesday, Friday is my clinic or OPD, and then Tuesday and Thursday is my day for surgeries.
What that patients have to wait for a long weeks to meet their doctors. Is it true, or?
It's very true. That is the number one complaint.
We wait for the patients and their patients wait for you.
No, that is such a big issue. We're always trying to get patients in as soon as possible. That is a constant struggle, because, I think, I know everyone, in our, viewership would agree with this, that our patients always feel like, oh my God, something is coming out of my, the vagina, and I have to be seen right away, And we always say, oh, this has been going on for a while. This is okay, but they, they're scared.
You have taken medical practicing license from so many states of America. Is it mandatory? One license not work for the entire country.
No, so each state requires its own license. So because I had to move, for all my training and everything, I did have different license, So um, my there's one license that I have, on my record, which is my Pennsylvania state license, which I took because when I finished my training, my residency, I thought that I would go to Pennsylvania because my family lives in Pennsylvania. So my older brother, my parents, everybody lives in they live in Pennsylvania. So I thought that I would go there, but it just worked out that I actually never worked, so I never used that license. Yes, but other licenses were just because of my jobs and everything.
And that license is throughout your life, or you have to renew it?
You have to renew it. You have to renew it, and you have to maintain certain, the requirements for it also. So some license will require a certain amount of training that's ongoing that has to be, continued.
In our country also, every state has a separate license. But
Right.
now Modi ji is trying that one license for all. So there will be universal license which can be utilized in each and every state across the country. You can use it. So
That would be great. I think that's a great idea because, there's certain states which have lesser, access for healthcare for patients. So if somebody is willing to, do like a trip even, or cover some areas, and go there and not have to worry about, taking a license and everything. So they can actually provide care.
be very nice and very helpful to even the patients and even the doctors. But still it is in being thought of. It's not yet implemented.
Yeah, we do have reciprocity here. So if one state gives you a license, then you can ask for another state to give you based on the credentials. Yeah.
Agreed. You are an active member of so many medical organizations at local, regional, national, and international level also, which includes Indian Association of Doctors. Since 2010 until date, you are a member of that organization. How does it function?
So I could identify, earlier Dr. Palaniappan said that, everybody has to join the meeting when the president calls, and says, this is the plan. So, the Indian Doctors Association of Houston that I've been part of since 2010 is like that also. It's a group of Indian physicians. We're all Indian physicians and dentists that, are, it's a group for the community, basically. We want to inspire the local community, help the children in the local community, and also network amongst each other. Because Houston is so big, it's a big city, is spread out. So this gives us an opportunity to meet and network with each other, talk about our specialties and everything. And so it's a great organization. I've been part of that organization since 2010, and since last few years, I've become a board officer. I'm a secretary currently, and
treasurer also, I think you were treasurer.
Yeah, I was treasurer before. I'm a secretary now, and then next year I'll be the vice president of the organization. And so I really enjoy being part of the organization because we actually have each year. I chair the scholarship committee for Indian Doctors Association. And so we give scholarship to the local area kids, high school seniors, and for their merit and then based on their needs and their extracurricular activities that they can use them for their college education.
Very nice. We are coming to know so many things about Houston and about yourself.
Yeah, Houston is an amazing city. I would definitely welcome anybody, and
Yeah. My family, my sister is presently in Houston only. There is College Station called.
Yes.
So she's there, and her daughter is also there. So sometimes hope to meet you.
Yeah. I have my two boys go to college at Texas A&M University at College Station.
Okay. So we'll talk about it later.
I go there all the time.
Okay, I'll give the address and you can. They'll be very happy to meet you. There are so many awards and accolades to your credit. And when your name featured as top doctors in Houston magazine, what was your reaction?
So it actually, I mean, obviously it's an honor because the way that the magazine does that ranking, for the top doctor is that other physicians basically nominate you in your field. So, there's a survey that's sent out to doctors, and then people, other people are asked that who do you think is the top doctor in this specialty? And so then other physicians are voting. So when you get the award, it is, a little bit, you feel good that, okay, your own colleagues and other doctors in the community are seeing you as somebody, who is doing good for the patients. And so to me, that's a big honor, because the thing is that if somebody refers the patient to me, I want to make sure I'm doing the best job. So that way they also feel good that they sent the patient and I took care of them, in the best possible way.
Yeah. Have you ever been to FOGSI, AICOG?
I have.
Okay.
Yes, I have. I've had
Which conference did you attend?
It's been many years, actually. Dr. Vinit Mishra had invited me.
Yeah.
And
Yes.
I had the honor. I did a live surgery and everything.
Conference,
I'm sorry?
Ahmedabad.
Yes, yeah, and it is an amazing experience, because I feel like medicine is lifelong learning, and so for me to watch other surgeons also operate, and the skills that they had and everything, it was just amazing, So I really enjoy that part, that the collaboration gives us the opportunity to learn from each other.
This year, AICUG in Delhi, and I am in charge of the surgical workshop.
Oh, wonderful! Wow.
It will be under my so if you permit us.
I will definitely, yes. Please let me know the dates. I would make.
Yeah, dates are fixed. I will let you know. I will talk to you about it later, and would like you to be with us. Everybody will be very, very happy. I'm the coordinator, I'm the program maker, and so I would like to have you. So now coming to the real questions about urogynecology, your professional acumen. So coming to the medical questions. We will move on to your subject, your passion related questions. What is the number one about the patients? What is the incidence of stress urinary incontinence in your place? In India, it is very high. It is around 40%.
Correct. So the same exactly thing, in US also, almost 50%, around age 50. So as the patients are getting older, the prevalence is getting higher, and we see that very common. 50% of women at age 50 would have, these urinary incontinence issues.
Only the difference is that in our country, women, they don't approach to the doctors. They're very shy about it, and they think that they have done some sin, therefore they're having this problem. But there, I think they must be open about their problems.
Unfortunately, no. Unfortunately, this is the big issue. So I actually go in the community and I give, lectures to just the general public, at senior living, centers or, churches and, those places. And I go and give the lecture, and one of the slides that I present is exactly on what you just mentioned, is that, patients literally wait anywhere between 5 to 7 years before they seek care. They don't go and see anybody because so many reasons, cultural reasons, or embarrassment, jobs, they're busy. Most women, play a role where they're taking care of everyone else, husbands, kids, jobs, home and everything. So they just, a little bit of leak, they just put it off. And unfortunately, it just keeps getting worse as, everyone ages. And so that part of it, and then the second part of it actually is the lack of awareness even amongst physicians. There's so many times, you ask the patients and they'll say, that they talk to their, primary doctor or somebody, and they just said, oh yeah, just, do some Kegel exercises. And that's it. So that's the unfortunate part also, that I think urogynecology still needs to do more, collaboration and teaching with our own colleagues.
Yeah.
So we can talk about more things that we can offer to the patients that can be better than just Kegels. Kegels are great. Kegel exercises are fantastic, but still, there's a lot more than that.
So, for our viewers, mostly gynecologists, we would like to hear from you the pathophysiology of stress urinary incontinence in simple words, so that
Sure.
everybody understands.
Sure, of course. No, so one thing I tell everybody, it's a spectrum. We don't know exactly what causes it, but we think that, we know the mechanism. We know it's a mechanical issue where the urethra, which is supposed to be the higher pressure organ, and the bladder is a low pressure reservoir. So when those pressure different changes happen in such a way that now the urethra is not strong enough to maintain its pressure, urine leaks out. So any pressure on the bladder from exertion, the bladder pressure rises and the urethral pressure does not rise enough, and urine will leak out. So we know that the urethra is the culprit that cannot maintain the continence. But now, why is that? Is it because the urethra is out of its normal anatomic position, or we call it urethral hypermobility? Or is it just because the urethra itself has become very weak? It's not able, the tissue itself is weak, which is then, more like an intrinsic sphincter deficiency kind of a picture. Or it could be a neurologic issue. Somebody had previous surgeries or something, and now the nerves coming to the urethra are not, functional. And there's some deadening of the tissue, and now it's not allowing the muscles in the urethra to work properly. So it's a spectrum, I think, but we don't know exactly what causes it. But it's somewhere between the weak urethra, which is the sphincter problem, or a hypermobile urethra, which still has a good sphincter, but it's just not able to maintain the pressure because now it's out of its anatomic position.
After birth injuries, the pelvic muscles gets weak. Then
yes. So that's the thing. Yeah, childbirth.
The angle also of urethra changes, no? Because
earlier
it is abdominal organ, and then it goes down. So that can also be one of the cause. And here, in our country, most of the births take place in the villages. So that is taken by dyes, and also it is not properly, the perineum is not taken care of. So when they grow older, many of our women, they are sufferers of this kind of stress urinary incontinence. So it has to be taken care of, and the awareness would also be in our places also. We have to make them aware, and we should ask the leading questions.
Yes, that's exactly.
The leading questions is very important. So one very pertinent question, we wanted to an explanation from you. The difference between, because it is very tricky, so urethral hypermobility and ISD. So are there two different things, or it is only the same? So kindly explain this.
Yeah. So, the hypermobility, just as I mentioned, that, it could be a hypermobile urethra, which still has good, urethral pressure. So the closure pressure of the urethra could still be maintained. It's just that it's out, because it's now not an abdominal organ, it's out of its anatomic position. It is not able to withstand the pressure that the bladder is generating. So but the ISD, by itself, it's a weak urethra. So it could be out of its anatomic position or intra-abdominal, but it's still very weak. The pressure inside the urethra itself has dropped. So, typically ISD we define, based on urodynamic findings. So if we say a Valsalva leak point pressure or an abdominal leak point pressure of less than 60 centimeters of water pressure is ISD. Or if somebody has a maximum urethral closure pressure of less than 20 centimeters of water pressure is also ISD. Anything more than on a leak point pressure of more than 100, then we say it's a strong urethra. It's just, must be hypermobile. It must be out of its, anatomy, position.
So urodynamic studies necessary to differentiate between the two, is it?
It's not necessary. So there is this is a big debate right now, right? That is urodynamics required to treat stress urinary incontinence? And there was a New England Journal article that came out that showed that it's not always required that you have to do urodynamics in an index patient who doesn't have any other issue. So if they don't have any prolapse, if they don't have any voiding difficulty, they don't have any urgency, they haven't had any prior procedure or treatment that has failed or anything like that, and if they cough and they leak urine and you can see that this is either a urethra that's hypermobile or or not able to maintain continence, you can treat it without urodynamics. But it's rare that you're going to find somebody and I use urodynamics routinely because I also want to know how are the muscles coordinated. Is someone a Valsalva voider or somebody not a Valsalva voider? And what is the detrusor a function on a pressure flow study before I do anything on the urethra? So I use urodynamics routinely, but the debate is that is it always required? And that there are people who say no.
So for urethral hypermobility, what are the tests apart from urodynamics?
So most of the time, I mean, traditionally, we always teach everybody.
You all still do or not? Q-tip test? No.
We don't. So one of the things is PopQ. PopQ is basically also if you do it, and if somebody is already at a -2, on a AA, then you already know that the bladder neck has deflected 30, 1/3 down. So I really don't always have to do a Q-tip test, but traditionally that is and there's so many imaging studies now. I don't routinely use it, but people do use ultrasound. MRI and ultrasound.
Even ultrasound, perineal ultrasound can help.
Correct.
So we have discussed already now what are the diagnostic modality for SUI in your setup. It is now, you said it is urodynamics.
Yeah, I use urodynamics.
Okay, I wanted to know about your setup only. Besides mid-urethral slings, what other treatment option you offer to your patient?
So when I talk about the treatment options, I always start with non-surgical treatments. So we always talk about, as I mentioned, one of my roles at job is I'm the medical director of the Pelvic Floor Center. We have a huge pelvic floor physical therapy place with a lot of physical therapists that I work with, and we routinely offer that as a first-line treatment to all our patients. So if somebody, so it's a shared decision.
Kegels exercise you offer.
So they actually, they do the whole, the bridges and Kegels, and they use biofeedback and so many devices also. And so there is a program.
What about Emsella chair, Thermiva, Emsella chair?
Yes, Emsella is also very popular and everything. So those are, the one option. If somebody is not a great surgical candidate, we can always also talk about incontinence pessaries. Right, so the pessaries with knobs, so those are an option. But then I get into the surgery conversation, and I tell them that mid-urethral sling is our gold standard for the treatment, but it does involve mesh. So then we have to have the conversation. Is it okay? I offer it. I tell everybody that we recommend it. It's very safe. The risk of associated with mesh is very low, although there are some people, some concerns about using mesh, and some patients don't want mesh. There are patients who come in and they'll just say, I don't want any mesh. So then I do offer them other treatment options. I talk to them about a BERT. I talk to them about fascial slings. And then I also offer urethral bulking injections.
What are the bulking agents you use?
So in the past, I've used the different bulking agents, which were, coaptite, it's a brand name, but it's, calcium hydroxyapatite. The other ones that I've used is Durasphere, which is carbon-coated zirconium. Macroplastic is also a brand name, which is also an isomer that you can inject.
Bulkamid is also a brand name, I think. Bulkamid.
Correct. So lately I've switched over to Bulkamid. So as in the last 2 years, I use Bulkamid because Bulkamid is the only agent which is non-particulate. So all the other ones, are particulate. There are particles that are used to inject in the submucosa to create that cushion. But then the particles can cause, granuloma or some kind of a tissue reaction as the fibrosis is happening, versus Bulkamid is 97.5% water and just 2.5% polyacromide gel. So that pretty much it combines with the water in the tissue, and then as the tissue creates the fibrosis, the water part actually even goes away, and then the cushion is maintained. The cushion that's used.
Yeah, do you have to do different sittings for this, or one sitting lasts for lifelong?
So lifelong is the tricky part. The studies have gone out
or
up to
more
7 years.
more than 5 years, I can say.
Yeah, so exactly. So I tell my patients that between 5 to 7 years, are most of the studies associated with Bulkamid. The data is pretty good up to that time. But after that, it's we don't know. We don't know how long it'll last, but in theory, it should last. As far as in one sitting or not, almost a third of the patients actually end up, getting what we call like a touch-up. So their cushion is not as big anymore, so the urethra doesn't coapt, and they require that you go back and you lift that cushion up again so that the coaptation is again created. So almost 30% of the patients will require a second sitting, but majority of them still do well just with one sitting.
About that, this treatment is very, very costly.
Actually, it's not the cost. Actually, it's not very costly. The injections, depending on what part of the country in US,
Our country, still we don't have this.
Okay. I hope it comes, because it's a very easy setup. In fact, so the northeast part of United States, New York area, and Massachusetts, all those places, a lot of people are doing it in their offices. All it requires is just the
like OPD procedures, small setup also can do this.
Very small setup.
Injections anyone can give.
Yeah. They have a proprietary, cystoscope, which is a very small cystoscope. It's a one-time purchase that you buy. It's right now, about $1,500 to $2,000 purchase for the cystoscope, and then they sell kits, which are disposable kits, which come with the injection material. And so for each patient, right now for us, the reimbursement that physicians get for the supplies and the injection part and everything, the insurance company, it actually comes out to be almost even. So whatever we're spending to purchase the kit and the equipment to do it in our office or the hospital, the reimbursement is about even. So you don't make it's not like, this is a very profitable thing or anything like that. So, but it's a great option because you can do it right there and there in the office, and there is no recovery. There's no recovery. Patient can go and that day go out dancing, go to dinner, movie, anything. And the stress incontinence is treated.
Yeah, and even for the patients who have bad surgical risk, for them it's a boon, because otherwise nobody would have allowed them to go for surgery.
Yeah, and the elderly patients, it requires a little bit of healing time and all that. If you do a sling, sling is still a surgery. There's still anesthesia, everything. So it takes, this one is, very little.
And do you do Birch corpus suspension still?
I do. I do it. I do it because I still feel like, I want the trainees to learn that.
Yeah.
I really feel I actually still do open. I do open. Yeah. I'm old fashioned. I tell my residents, that I always want to feel the tissue. When I take a suture, I want to make sure that I'm taking a good bite. I don't want that failure to then be in the back of my mind thinking maybe the stitch just, tore. or anything like that. I want to make sure that I have a good, purchase and everything. So I still do open.
How do you select your patient for urethral bulking injections? How do you select? Select, we have already talked now.
Yeah. So same exactly that we were talking about, that somebody who's not a good surgical candidate, somebody who
Doesn't want this.
yeah, risk of anesthesia, somebody who, has already, failed some procedures. You've already done, 2 slings, it has failed. You've done a fascial sling, nothing is working. You can just bulk the urethra and just, make it very, tight, a little bit, so that way urine doesn't leak out. So that's also a good candidate. Any patient, who doesn't have, there's so many people who are working nowadays and they don't have the time for recovery. They're always on the go. They're in a high position and they say, I cannot, take time off for 2 weeks to recover. So, with any lifting restriction and all those things. So, there's so many indications that I feel that, bulking can at least be offered, and then, at least make them better. And if there's, later on, if they choose to, they can still do another procedure.
You seen them? Do they come to you after getting injections? Do they come to you to say that they are fit and fine, or they come with some complaint?
So I will tell you, I've done this for the last 2 years. I do them pretty frequently, and out of all the ones I've done, I have one patient who had chronic dysuria. She felt like there was always some burning every time she urinated. So that was very challenging to treat, because, the material is already injected, and, so it required, a lot of, anesthetics and all of those kind of things to at least keep the urethra from, feeling irritated every time she urinated. So that's my one patient that I always remember. And I tell all my patients, anytime I do the consent for the urethral injection and I talk about, I risk the benefits and everything, I always bring that up and I said, there are some risks, including, the dysuria, which can be, pretty challenging.
Because when you apply mesh, after mesh treatment, many women come to us complaining of dysuria, pain in the lower region, perineal pain.
Yes.
Therefore, they don't want mesh.
Yeah. So this one is rare that, I find this, but like I said, and out of all the ones I have one patient, so I always remember that.
By the way, I asked you because even I think we will talk about it in our AICOG workshop. It's a new thing, new incoming treatment modality. So we will keep it, and maybe we'd like to invite you for this. We'll try.
No, definitely. I think it's a great option. I think that at least, it's a simple enough option that at least you can offer. And if somebody
tremendous relief, that is best part, tremendous relief to the patient. What do you want?
Correct. Absolutely.
So we have finished all of the questions. One small question. What is new in the horizon for stress urinary incontinence treatment? Either it is stem cells, lasers, or new polymers.
Yes. So you covered all of them. So I think all of those are coming out more and more. I think the issue is that, even though we always say our mid-urethral sling is our gold standard treatment, more and more people, offering mesh is becoming hard. More and more people don't want any mesh. They're saying, no, what else can you do? And so when I talk about other, birch or, fascial slings or anything like that, even if it's laparoscopic, it's still more invasive surgery. Yes. So I think that, as far as something that's less invasive but still gives very good result, urethral bulking injections are becoming more and more popular amongst patients. And so because of that, there's a lot of new focus on different type of polymers being used, or even using patients' own muscle and stem cells being injected. There's a trial going on, the Celebrate trial, which is going on right now, which is being tested it's a multi-center trial, and looks like it's the results are promising that that will be something that will be offered. And then laser. using laser to actually kind of, create that more collagen synthesis also along with the bulking. So the bulking is being, offered, and then the, simultaneously the laser will create more collagen synthesis.
I think sufferings of our women will come to end by the newer modalities of treatment.
It's very much needed because there's so many people. I always tell my patients that, the pad industry is much bigger, than you can imagine, than what we offer, and the medical, the side of the treatment side of stress incontinence. More people pick just pads and continue to live with that.
Yeah.
And that needs to change. We need to make a better
newer
effort.
modalities where this is non-invasive treatments, stem cell, or this your urethral bulking agents, or the polymers. They are non-invasive, and many women, if they will come, they will become aware about it. They will come to us, and that will be a great relief to our women who are growing older, because the longevity has increased. Earlier, the women used to die at 40, 45. So they never experienced this type of problems. But now the longevity, women are living up till 85 years.
Sure.
And very much their perineum gets weaker as they grow older because of the lack of estrogen. So these people, the women, now they will not have to suffer silently, because the treatments are here. They're non-invasive, not much costly. So I think because today's podcast, it is not only for the gynecologist, the viewers are also from other, the general public is also there. So for the viewers, I've taken all these questions, and when I discussed with you about the questions, my aim was to tell them, to make them aware that we have treatment that is non-invasive, not much costly, but please come to us, so that you get relief, lifelong relief, and don't hesitate.
Absolutely.
Please be open and talk to us. Don't talk to your neighbors here and there. Come to us. So this is a message from your side and from FOGSI to our viewers. So
absolutely.
We are almost touched the time, 1 hour. I don't know how it passed. So it was lovely, and we are lucky to have you today at the podcast platform, and see you some other time on some different platform. And
thank you so much. I really appreciate it.
For the AICOG, I'll try my best to call you. Thank you so much.
Thank you so much. I look forward to it. Thank you, everyone.
Fascinated to Delhi, so I told you it is in Delhi.
Wonderful. That would be the best.
Thank you.
Thank you so much.
So, good night. Thank you.
Take care. Bye-bye.